hashtag healthy communities for those that like to live tweet. The lectures are brought to you by our esteemed chair, Councillor Ketan Sheth, the Advocacy Project, Healthwatch Brent, but also Healthwatch Westminster, Kensington and Chelsea. So tonight's subject is dear to everyone's heart. Can we have a GP system that works for everyone? There'll be plenty of opportunities to ask questions and engage with our expert speaker. So please pop them in the chat or raise the hand button. So I'm going to hand over now to, okay, so somebody's saying the sound level is too low. Cleo, if you could have a quick look at that whilst we carry on. So over to Councillor Sheth, our chair, a powerhouse creating positive change, a lawyer, respected councillor in Brent and lead governor at CNWL. And Councillor Sheth will introduce our distinguished speaker. So over to Councillor Sheth.
Thank you, Judith. Thank you, Judith, for that wonderful introduction. It's really so good to see a great many friends this evening. And can I also add my welcome to you all. This evening's theme is all about GPs, as Judith has just alluded to, and primary care. Primary care is the foundation of the health service, and GPs are the bedrock of the NHS, seeing the big majority of patients delivering the most care. This status comes with privilege and responsibility. Privilege because the NHS remains one of the most respectable public services, and GPs are probably the most significant, actually treasured link patients have with the NHS. Responsibility because just over 1 million, that's 1 million GP appointments occur every weekday across the country, providing patients with safe space to share information about the illnesses, woes, and challenges. And GPs are the first point of call when someone is not feeling well. They help everyone to access timely and safe healthcare. However, getting that all-important GP appointment, and particularly a face-to-face appointment, is now far more difficult and stressful than ever before. I accept that the need to limit the spread of COVID-19 during the pandemic and the uncertainty around it has exacerbated this interaction. However, as we emerge from the pandemic and more appointments are being given, there are still too many who find that too difficult or somewhat limited. And I know that the nature of GP practice is so much different now. And our expectations have shifted too. People want instant access and on demand, because when we are not feeling well, nothing is more important than seeking that immediate help to get well again. So when we aren't feeling well, we all have the same usual questions. Why can't I get an appointment? Why can't I see my GP? Why do I have to go through so many hoops to get a blood test? Of course, all those questions are valid, but we have all watched on news bulletins and read in newspapers about staff shortages, GPs retiring, the lack of infrastructure and investment in the NHS to provide this level of service. On the other side of the coin, we need to say that anger at reception staff is not going to help. Actually, it makes the position worse. But clearly, something needs to be done. Let's co-produce some solutions that help patients and primary care staff. So how do we bring more appropriate care to our patients and continue to be safe and effective? How do we build multidisciplinary teams to ensure continuity of care? How do we ensure the use of technology is used effectively and safely? How do we bring diagnostics into the community? To explore some of those questions and others, I am pleased to be joined by my friend, Dr. Chand Nagpal, CBE. I know most, if not all of you, will know him. Chand is a senior GP in London and was the first ethnic minority chair of the British Medical Association Council from 2017 until recently. He has dedicated his professional life, spanning over 3 decades, to improving the working conditions of doctors in the UK and to lobbying for the NHS to be able to deliver equitable, comprehensive quality care and address health inequalities. His national work began after being elected onto the BMA's GP committee in 1996, and he was subsequently elected as its first ethnic minority chair in 2013. In 2017, as I've just mentioned, was elected as the first ethnic minority chair of the BMA's council in its almost 200-year history. Wow, Chand, well done. Throughout the pandemic, Chand represented the profession in crucial discussions with government and NHS leaders. He has been vocal on the pressures affecting the NHS and frontline staff. Most notably, he was one of the first national figures to publicly call out the disproportionate impact on pandemic on the ethnic minority and demand a government inquiry to address this. And friends, this evening he's with us, and I'm so pleased. Thank you, Chand. So if you can all welcome Chand, so excited to have you. I know how busy you are, and thank you very much for giving up so much of your precious time to be with us this evening. So friends, I'm now going to invite Chand to provide an overview about GP's practices, particularly from his very lengthy experience in the profession. Of course, 1 hour is not going to be enough, again, for this incredibly complex subject, and we know how much we have been hearing and reading about this in press. So we'll try and see how far we can take our conversation. But this evening session is just the start of that conversation. And Chand, if I can ask you to spend about 10-15 minutes, and if you could provide us with a general overview, insight into the GP practices, it would be really good. Thank you very much.
Thank you so much, Councillor Shayat Ketan. It really is, it's my pleasure to have this opportunity to talk about something that really is my lifeblood, which is being a GP. In fact, if anyone asked me what was the most difficult part about being chair of the BMA Council, I would have said, and I have said, it was being away from my practice and being away from being able to carry on seeing my patients on a day-to-day basis. And I'm so pleased now to be able to do that once again, having concluded my term. I'm going to be running through a few slides, not for the purposes of lecturing you, but really to give you some thoughts for discussion later. I'm very much looking at this tonight as a conversation. 1 second. Can you see my slide? Can you see my slide? Okay, so I'm going to actually make it slideshow so that it's 1 second. Just bear with me. So as I said, this is not for the purpose of lecturing. It's just really a chance to give you some ideas around general practice, the realities, and discussion later on. So I'm going to just first start with, hang on, what's happened here? Just saying a little bit about myself. So I chose to become a GP as a very positive career choice when I was a medical student. I'd always wanted to be a hospital doctor, but when I walked into a GP practice in inner city London as a medical student, I was quite literally overawed at the GP trainer, who to me worked magic, seeing a newborn baby, seeing a person at end of life, and everything in between. From patients with asthma, mental health issues, drug misusers. It was an inner city practice. And what struck me was the incredible skill of being able to manage that whole spectrum of medical conditions, but also the trusted relationship, which I had just not seen in hospitals. And that trusted relationship to a point where patients would confide with their GP on issues that they wouldn't even have shared with their loved ones. And from that moment, I felt this is the job I wanted to do. And in fact, it wasn't easy. Becoming a GP in those days was very competitive. It's hard to believe when you look at things now. And in fact, there were 80 applicants for the single partnership position at my practice in Honeypot Lane. So I finished my training on the 31st of July, 1989. On the 1st of August, the next day, I became a GP, and I've been in the same practice for 33 years. And in those 33 years, gosh, I today see adults, successful adults, who I saw as babies when I first started. So it's a fantastic experience to be a GP for me. Huge changes over the decades. When I first became a GP, I was working a rota of 1 in 4, where I'd be doing a whole night on call and going to the practice the next morning. I was, a hostage to my bleep on weekends, family occasions, even friends I couldn't meet. That was the reality of general practice. It has changed over the years, and we've seen the role of GPs transform, IT innovation. We're now paperless. When I started, it was all paper. There's still a lot of paper in hospitals, mind you, but it's totally paperless in general practice. The professional workforce has expanded. The GP premises have become far more modern and bespoke. And we today now work in groupings as well as practices called primary care networks. I've represented GPs for most of my professional life, as you heard, in the BMA GPs committee since 1996. And I've negotiated directly on behalf of general practice with government, with different health secretaries, and more recently, in the last 5 years, as chair of the BMA Council, I've seen the role of general practice within the entirety of the NHS with the colleagues, with hospital colleagues I've represented as well. Now, if I just look at my own practice, the transformation is clear just in the last 7 to 8 years. So in 2014, we had 8,000 patients. Almost all doctors were full-time partners, 2 nurses, reception admin staff, and a practice manager. If I look at the same practice today that I'm in now, we have double the number of patients, we've got double the size of premises, fewer GP partners, sadly, we cannot recruit, a bank of locum GPs, who we never had before. We need locum GPs, we just won't have the slots. But in addition to the 2 nurses, we've got 4 pharmacists, prescribing clerks, healthcare assistants doing health checks and blood tests, 2 physiotherapists, enhanced nurses looking after the elderly doing home visits, social prescribing link workers who are fantastic, business manager, admin call center, an admin referral team just doing referrals all the time. We've got an online consultation triage staff that every day look at online consultations so that they are directed to the right professional. And we have an operations manager. So general practice has really, it's almost indescribable to me, to the practice that I joined 30 years ago. But also the workload and the role and the remit of general practice has also expanded inexorably. You know, when I first was a GP, we spent a lot of our time referring patients for specialist care. Diabetes was entirely managed almost entirely managed in hospital clinics. Now it's entirely managed in general practice. We have older patients. Life expectancy has increased literally in the 3 decades I've been a GP. Many more patients with complex, treatable multiple morbidity, a massive increase in care moving out of hospitals and into the community. We're now managing patients at home rather than admitting them in a way that I've never known before. Many of you will know, if you're patients, that you have in recent years seen how hospital clinics are discharging you to your GP. So we're seeing more and more specialist patients. They're being discharged at a much earlier stage. So we're seeing people much sicker when they're discharged, looking after them as they come home. You know, when I was a GP, patients were in hospital for a week after a heart attack. They were in hospital for 10 days after a knee or hip replacement. They're discharged literally the next day now and looked after in the community. And a GP's working day, people obviously will look at the consultation times. You do a morning and evening surgery where we see 16 to 20 patients at 10-minute intervals. I can tell you that's exhausting in its own right. It's you know, just imagine trying to see a patient with multiple morbidity in 10 minutes. We see lots of extra patients on the day. We have patient queries in real time, e-consults to get through. We have to telephone patients back. We get calls from hospitals, community healthcare professionals, literally in real time about issues, about discharging a patient, for example. Many urgent prescriptions that have to be done between patients or afterwards. Something that people don't realize is I probably spend as much time in clinical administration than the time seeing patients. And that goes between surgeries right into the evening. We have to read probably something like 100 letters that, well, to the practice, probably 180 letters that come every single day with information about patients who've been seen in clinics and discharged. Those letters contain enormous lots, a lot of important information about what we as GPs have to do, like change drugs that they've been discharged on, follow them up for a particular blood test and so forth. About 200 pathology results on a daily basis we have to read and action. Those are results that do need actioning sometimes on an immediate basis. Last Friday, I got a result, you know, at about 6 o'clock in the evening on a Friday. I had to manage a very low blood count that needed treatment on a Friday evening, and that went on till about 8 o'clock. We do home visits. We complete medical reports, and you will know that. You've been to your GP often. Some of you will have for medical reports. We, as partners, have to manage the running of a practice. You need time for that. And we, of course, you know, most of us who are partners responsible for our practices are working on nights off, in the evenings and on the weekends and on our days off. Now, we've seen a change in demographic of GPs where increasing numbers are now wanting to work as locums or as salaried doctors because they can define their workload and not have to have this open-ended responsibility to manage what is an unpredictable demand hour by hour. We, in spite of everything I've said about the expanding role of general practice, we have 1,800 fewer whole-time GPs than 2015. There are more patients per GP now than ever before. We're also finding GPs working less than full-time. And I say that, you know, I think the word full-time is a misnomer because the job weight, the job intensity is such that many just cannot, they need a bit of space. We have different categories of GPs. Almost everyone was a partner when I joined. We now have partners, but they're shrinking in numbers because doctors, GPs do not want that responsibility that I described earlier. So we have increasing numbers of salaried GPs who define their workload. They don't have to, for example, deal with hundreds of extra results that may come through the door if that's not in their contract, but you have to mop it up as a partner. Locums who specify how they want to work. They often don't want to do home visits. They certainly, most of them do not want to do the clinical administration I described. And we have portfolio GPs who are working in general practice, doing education, working for the CCG or ICS or whatever we're now called. And so what's happening is that the partners, those like myself who are responsible for practices contractually, are shrinking in number, feeling much more stressed, because you have to do what you have to do. And the number of partners is reducing. So more and more GP partners are choosing to either retire or become salaried or become locums. And in many cases, practice contracts are ending with the contract going back to the now to be the ICS. Another very specific, bizarre issue is perverse pensions. It's a very specific niche issue, but you get to a point where GPs and senior GPs will always have to pay to go to work. That the normal pension contribution is 30% for GPs. It's huge, 28.4%. But in fact, after a certain threshold, you could end up paying so much in tax that it's worth retiring early, which is crazy. Something the government now says they want to address. GPs don't like working like this. We don't feel we can provide patients with safe care in the conveyor belt pressure we have, an unmanageable demand. Many are upset, of course, you heard earlier from Ketan about increasing abuse, but also abuse directed at practice staff. And I just want to say that what you're witnessing, what I'm witnessing, what we're all witnessing is simply a mismatch of a lack of capacity, lack of GPs, lack of appointments, and demand that far exceeds it. It's no different from being in a local supermarket and seeing this massive queue to the cashier when the other 4 cashier desks are empty. You don't blame the cashier for the fact that the other cashier desks are empty, counters are empty. You realize there just aren't enough of them. And that is the reality of general practice today. And the problem is that these pressures are resulting in increasing numbers leaving the profession earlier. So retention is a very serious issue. And if you couple that with the demand of the backlog post-COVID demand, we're in for a perfect storm unless something is done. So what can be done? And I think that, well, first of all, we can't magic GPs up from nowhere. We certainly do need to have investment, but we need to retain GPs and we need to manage workload more effectively. So with this shortage of GPs and demand, in 2015, NHS England identified that 27% of GP appointments are potentially avoidable. So for me, one of the first most obvious no-brainers is liberate those 27% of appointments and make them accessible for patients who are acutely ill or patients who need to see a GP. In fact, when I was negotiating on behalf of GPs, I said to Jeremy Hunt, when he said we're going to have 5,000 more GPs, I said I can give you 8,000 more GPs immediately, literally by liberating these wasted appointments and inappropriate use of GP time. That would be the equivalent of 8,000 more GPs instantly. We have, of course, now a choice of appointment systems, and I want to be a little positive about this, because although it's absolutely right that anyone who needs to be seen face-to-face should be seen face-to-face and also have a clinical examination, I'd be the first to say that, you know, these other forms of appointments have transformed the experience of many patients. People do not have to take time off work if they can have a video consultation. Many find online consultations extremely effective. I needed a repeat prescription for my GP last week on a Friday at 5 o'clock. I requested it online. Within 20 minutes, I got an email to say I can pick it up at my pharmacist. You know, in the old days, I used to shudder at trying to get through on the phone to my practice. So, you know, these things can make a big difference. And we need to, I think, make sure we embrace the appropriate use of appointments, which really can be right for patients and right for use of GP time, but also seeing the right person at the right time. And for that, you need to have some system of triaging and signposting. The second area which can really make a difference in my view, and again, you will appreciate this as patients, is the interface between general practice and hospitals, primary, secondary care interface. Every day in general practice, there are thousands upon thousands of appointments that are taken up for purely bureaucratic administrative purposes and nothing to do with patient care, such as seeing a GP to issue a prescription that has been generated in a hospital clinic. Ask your GP to prescribe X, Y, or Z. Patient takes up an appointment. Requesting investigations. Go to your GP to have an X-ray in 4 weeks. Repeat a blood test in 6 weeks. A GP appointment taken up. Solutions for both. There are solutions. The first is give hospitals electronic prescribing so that they can press the button and the patient can go to their pharmacist of choice. What we can do in general practice. I've repeatedly advised the government to do that. Hospital investigation of the community, again, the solution, allow hospital doctors to book directly, bypass the GP practice, allow those appointments to be available for sick patients in general practice. Chasing up, informing of hospital test results. Every surgery I do, patients are asking me, have you got the MRI I had in my hospital clinic last week? Actually allow patients to get that information directly from hospitals. Chasing up hospital appointments. Appointment occurs in general practice. To say, I haven't heard about my follow-up. I've waited 3 months. I was told I'd be seen in 2 months. All of this needs to be directly available in terms of communication between patient and the provider, which is the hospital. And these systems need to be put in place. Expediting hospital appointments is another. Queries about something that happened in a clinic and really wanting letters to be translated. We need to make sure that we get this interface right so that we minimize these bureaucratic appointments, which are significantly reducing our availability. In fact, 40% of GPs say that 20% of appointments are wasted purely on waiting list queries. And with the backlog now, that has escalated to unprecedented levels. The next area is managing demand and patient empowerment. And I do believe, and I've seen, plenty of great examples where patients, this isn't about not seeing a doctor when you need to see a doctor. This actually works for patients with empowerment to actually better manage their own health and with better outcomes. Huge role in patient education for self-management. That could start in schools in terms of education for self-care. Free blood pressure monitoring is a simple example. It should be on prescription. It's about £25 to buy a blood pressure monitor, but in fact, on prescription, patients can just self-measure and not come to a GP. Also having access to test results and so forth. So huge potential for improving access. IT, similarly, huge potential to improve access to GPs by empowering patients to use the NHS app and expanding the use of NHS apps. Far too few patients make use of that, but if they did, I think it'd be a significant impact on the availability of GP appointments. But of course, digital literacy needs to be improved, and we must avoid a digital divide. But also remember that technology can also be assistive, and therefore for many patients who don't have good eyesight, housebound patients, Alexa-enabled voice technology can also make a huge difference. And I mentioned earlier, we must make better use of skill mix, and that means enabling the public and patients to understand the range of professionals I described earlier that are available, because there's no point seeing a GP for a question about housing when in fact we've got link workers. No point seeing a GP for shoulder pain when a physiotherapist in the practice can provide a better care. That requires signposting, triage, and greater awareness. And I wanted to just say that in all of this, equality of access in general practice is paramount, and sadly that isn't the case at the moment. And we know that there are cultural and language barriers and plenty of evidence of inequalities in access, treatment, and outcomes. Only last weekend in the newspapers, there was a report that patients of Black origin actually have their cancer presentation delayed in terms of coming to see a GP, and their outcomes are worse. So, there are reasons why we need to really look at equitable access for the entire characteristics of patients we look after. And finally, of course, this isn't your role in this meeting, but we do need the government to do a lot more. And the most important thing, if I'm speaking on behalf of GPs and our staff, is that we need a narrative that explains to everyone why we are under pressure and this mismatch. It's not our fault. It is the system that is under pressure. It's not just, ambulance queues that are under pressure, hospital A&Es, it's also general practice. And please don't scapegoat us for that situation. We need to have dedicated funding for general practice, not just for certain visible acute pressures, for example, in hospitals. And we also need to make sure that we use GP services wisely and appropriately with proper investment for IT. And as I said, we need to improve the working conditions to retain the workforce we have if we're not to see a further shrinking of already an understaffed general practice service. So thank you very much for listening. And as I said, nothing I've said is anything laid in tablets of stone. Those were just some thoughts from myself. You're welcome to disagree with what I've said to have a fruitful discussion. So I look forward to that discussion now.
Thank you very much indeed, Chand, for that fantastic overview, that very helpful insight into the stuff that happens in our GP practices day in, day out, and the pressures of the demand and the evolution that is taking place. Now, Chand, I want to go back to my opening remarks, and in particular, the accessibility. It was really good to hear about many pressures that you highlighted. And also you talked about various solutions, potential solutions. But what can be done? How can we work together right now in short-term basis to ensure that those who require those appointments are able to get those appointments? And I know that we have our colleagues from NHS, from Brent here, and I'll bring one or two of those colleagues in a moment. But what's your view about the short-term solution, about working together to resolve those difficulties?
So, Ketan, I think the most important is to liberate about the quarter of GP appointments that are avoidable, or rather that are wasted for reasons that are not to do with patient care. Do that immediately. So at the moment, we have 6.5 million patients on a waiting list backlog. I've advised the government, and they said they want to do this, but it hasn't not yet materialized. Just make sure that patients have a helpline, something as simple as that, to find out where they are on the queue and to actually know when their next appointment, when they will be seen. It is of no value seeing a GP and blocking up an appointment purely for that purpose. And if you multiply that over, and if a quarter of appointments are taken up in every GP practice, those are appointments which should be available for people who are ill, people who need long-term follow-up and so forth. So that would expand capacity at a stroke. And that sort of thing is one example. And I gave you all those other examples also of those pure bureaucratic demands, which I think are within the gift of local healthcare systems to actually make a difference. So one is, as I said, the waiting list management, remove it from GP consultations. That's just not appropriate. And all of those other examples I gave you about how we are asked simply to do clerical work often in an appointment, remove those with those solutions that I described. There's no reason why you can't design systems that allow patients to have access to prescriptions in the community rather than getting the GP appointment and so forth, or whether they are follow-ups directly requested by hospitals, etc. You know, if you were shadowing me, you'd understand the scale at which patients are being denied appointments because of these other wasted appointments. And make use of the skill mix. There are fantastic other staff who can actually provide appropriate, even better care than a GP for a specific type of problem, and let patients be seen by the right professional. We will then be more available for patients who need to see a GP.
Thank you. And Jonathan, thank you for joining. Really good to see you. Jonathan is the leader here in Brent from the NHS. Jonathan, how practical and how easy it is to make that available, make those appointments available that Chand is talking about, please. And I know, but perhaps, we'll go on to talk about, all the extra appointments that you guys have been providing. But I would just like your thoughts on how practical it is to make those appointments available, please. You're mute, Jonathan. Can't hear you. Okay, well, while we are trying to talk, okay, here we go. Can you, no, we can't hear you. Okay, we'll see if he can come back to you, Jonathan, but thank you for joining anyway. Chand, you then talked about in your presentation about face-to-face. And again, this is hugely important. I absolutely understand, as I was saying in my opening remarks, the need that arose during the pandemic to keep the system safe, all of us safe, to move away from face-to-face appointments. But as we emerge out of pandemic, I know that face-to-face appointments are being made available, but it is rather slow, isn't it? What is it that is holding up face-to-face appointments, please?
Ketan, I'm not sure that the current statistics show that there's a hold-up. In fact, 2/3 of appointments are now face-to-face. That's official statistics. And remembering, as I said earlier, that of course anyone who needs to be seen face-to-face should be, and I believe that in the vast majority of practices that's happening. If it isn't, then I think that's probably an issue in a particular practice. But ultimately, we do not have overall enough appointments because of this lack of infrastructure, which is pretty shameful when you compare the UK to other equivalent nations. And also, as I said earlier, let's not forget that for many patients, a bit like online shopping, we're not going to go back to before the pandemic and force everyone to go physically to shops to buy goods because they realize the advantages of online shopping. Similarly, there's a significant number of patients who want to be able to have the convenience of sending a photograph or having a video consultation, not taking time off work, and having that access pretty quickly, or the e-consult that I described that I myself benefited from. So we need a plurality of ways of seeing a GP, and I believe that's what the public want. So if there are individual issues, I suspect it's down to staffing and the fact that we do not have enough GPs and probably practices that are having difficulty in recruitment. We have not been able to recruit in 6 months. Not a single GP wanted to be a partner in our practice. So we've now had to have a pool of locums. So maybe in some areas, it's even difficult to employ locums as well. But I do not believe, and maybe the audience here might feel differently, but I do not believe that in the majority of practices, there is now a resistance. It's about appropriate use of GP time for the right reasons.
Thank you. And of course, the technology and digitalization of the appointment system is good for those of us who are able to access those technology and those technologies. But there are a great many people who are not fortunate enough to even own any of those devices or any of that technology. And I guess it's about balancing that, isn't it? And you mentioned about the benefits of all of that, but under the old system, the telephone appointments worked very well for a great many people. And I don't know whether we have Linda on the system. Linda wanted to put a particular question around telephone appointments. So, some of the stuff that happened pre-pandemic, perhaps we might just want to maintain that rather than completely moving away from those good old days. Chand?
Yeah, so the question was about telephone appointments.
Absolutely.
Yeah.
That it particularly worked well
Yeah.
pre-pandemic, and perhaps we might want to retain some aspect of
Yeah.
the good bits of the system that worked pretty well for many of us just before the pandemic.
Yeah, and remember, these aren't alternatives. So if I see a patient today and I examine them, I investigate them. In the old days, you'd make another appointment, and the patient would literally have to take time off, sometimes off work, just to walk into a consulting room and be told that their, told that their anemia is improved. I now will do the physical examination, anything that I need to do face-to-face. The next appointment, I know the patient, maybe a telephone appointment, and it takes a few minutes to just inform them of the results. So patients welcome that mix and match. And in some cases where the patient wants advice only, they will choose the telephone. So in fact, when you give your patient population, we've done this with our PPG, a choice of what sort of appointment they want, I think, it's quite surprising that significant numbers want appointments, a significant number want face-to-face, probably more. But then you've also got those that are loving the online consultations too, especially when they want a simple prescription and they describe what they need, or it's a repeat prescription and so forth. So I think it's really important not to have any blanket approaches to this, but having this plurality of approaches. But no one who needs a face-to-face should be denied it. And can I tell you from the GP's perspective, face-to-face appointments to me are far easier than telephone appointments. Telephone appointments, even the surveys we've done of GPs show that they take longer because you have to ask so many more questions to try and.
So I think, Chan, I think it was
option.
about. So Chan, it was about booking the appointment via telephone,
right.
rather than telephone appointment itself. And I think the process nowadays is much more like booking the appointments online, which many of our residents find it difficult in terms of accessing the technology. And I think Olin perhaps has a question around that. Olin, do you want to put your question to Chan, please, around technology?
Yes, I did. I've actually, so let me just take that off. Right, there we are. I've actually put it in the chat. So let me just read. It's basically how are you going to facilitate the use of increasing use of technology to make appointments, etc. I'm not just talking about the elderly, but also people with mental health issues, those that are vulnerable, but also the growing cost of living crisis that will mean that the use of data will be limited.
Thank you for that, Olin. Chan, please.
So first of all, when it comes to my what I said about equality, I do think the government does have a responsibility to make sure that people don't have unequal digital access, and to invest and provide the right digital enablement for different groups. And again, remember, technology can be assistive. A housebound patient could have a video consultation with a healthcare professional like a GP in a way that would be immediate and supportive. Alexa-enabled technology can help many to have home aids operating in a way that they couldn't physically. So it's not that technology is only for young people. It can make a huge difference also. And also, I've been surprised that with the right training, we shouldn't just assume that this is for able young people. There are many who make use of technology given the right training and given the right equipment and so forth. So I would make digital enablement, but for those that are not able to use or do not wish to, we need to make sure that they're not disadvantaged. Now, in some cases, if you have more patients who are making appointments online, for example, you'll have receptionists who are less busy and able to be available for those who want to be able to get through on the phone. So there are some advantages. There's a win-win in this. But the one thing we must do is, I think, monitor for inequalities, because the one thing we do not want to do is exacerbate inequalities.
Thank you.
I'll just do a quick comeback on that, just a quick one.
Yes, please.
My experience has been that I tried to make an appointment with my doctor and I was informed that I need to go online. I then said, well, I don't really want to go online. Can I just do it? And I was told, that is the way that we actually do it. And I'm not the only one who's had that experience. Other people in the community also have had that. And talking about government enablement and etc., it's never going to be as it should be. And as we know that, there are some people who are vulnerable, some people got mental health issues, they may be going through an episode, you don't know. So, I mean, you can't assume that the government's going to take that on immediately. And at the end of the day, it will fall back on the GP or on the National Health Service or services that provide to actually provide that service to that person, which couldn't have been avoided if they'd had that initial contact in some cases. So that's my point.
Thank you very much.
Councillor, can I just say that I think what you've described is absolutely right. What we must not do is have obstructive blanket approaches that everything needs to be online. And you need to have reception staff who, in the example you gave, should be able to say, okay, if you can't use online, how can I help you? And can I make an appointment for you in a different way? We must have that dual approach.
Thank you very much for that. Robin, thank you for your patience. You've been waiting there for a pretty long time. So here you are. Thank you.
Thank you. I'd like to take up what Dr. Nagpal said about the national scene. He mentioned Jeremy Hunt, who, as we know, was the Secretary of State and is now chair of the Health Select Committee. And in both roles, he has been asking for a national workforce plan for a very long time, and he's renewed it, as he's left office. But he's not getting any answer. And would Dr. Nagpal, who obviously does see ministers eye to eye, face to face, like to give his view as to why the government is absolutely refusing to have a workforce plan? Because the fundamental problem is a shortage of key people, and whichever way we look at it, I mean, it's GPs and it's nurses and it's all sorts of others. But what is the reason? There must be a reason. So
we are fast running out of time. Running out of time. Your comments and questions brief, and equally, Chan, if you could keep your replies rather as well. Margaret McLennan, you also had a point on workforce. So perhaps you might want to ask your question, and then I'll bring Chand in for a response.
Thank you very much, Ketan, and welcome Dr. Nagpal, and just say thank you very much for everything that you've done in the past. It's always your words and commentary were always very reassuring. I can't say for the others, but you were reassuring. What I wanted to ask Dr. Nagpal in terms of the, I think Robin touched on the point about a future workforce planning. Do you foresee that in future, the point of entry will always be the GP? How do you foresee in the future how the community will be able to, and I call it consume their health requirements? You also see a change in how they start consuming cosmetic health, and everything's online, everything's much more easy to access. So how do you see in future, natural health services will be consumed?
Yeah, well, already we're seeing a plurality of access points to primary care, and I think that's right, and I think that will expand, and that's right, because GPs should be doing what GPs are best at doing and what GPs need to do. So if you have a mother with a newly born baby, contacting the health visitor will be the right thing to do when you have an issue around feeding. I hate to say that as a GP, I know far less than a health visitor when it comes to feeding issues or weaning questions and so forth. Patients are going to the pharmacist directly. Those that want to can get information digitally and they're doing that increasingly. We have in our own practice the ability for patients to go and see a physiotherapy directly rather than seeing a GP if they have musculoskeletal problems. So I think we're going to see much more of that. But the most important thing in all of this is that where a patient does need to see a GP and wants to see a GP, we should not be putting barriers and forcing them down other routes. We must always retain that accessibility.
Thank you. Thank you, Robin, and thank you, Margaret, for your questions. Let me bring Nitin. Really good to see you. You have already put your question in the chat, but let me bring you in, Nitin, for your question.
Thank you. Thank you, Ketan. Thank you very much for sending me the invite. And Chand, it's really good to see you. And thank you so much for all you've really done over the past so many years for us as patients and colleagues. My question is not the one that I put in the chat bar. I'm thinking of a solution here. Can we have improved working between primary and secondary care? I'm talking of the sharing style clinic that we run in East Kent over the last 7 years, where sometimes when you need an opinion from a hospital specialist, the waiting list in the hospital is much longer. And if we can run some form of joint working between primary care and secondary care consultants, we could, help our patients get a secondary care opinion faster. What do you think of that, Dr. Nagpal Chand?
And
Well,
Chand, there's a much bigger question here as well, back of what Nitin is suggesting. If we crack this access and appointment situation, then surely the pressure that we hear and read in the newspaper about hospitals, A&Es, and ambulance perhaps might also help the situation, right?
Yeah, so I think that what Nitin's past council member, so he's a colleague at the BMA. I think what Nitin has highlighted is the desperate, long overdue need to have service redesign so that general practice and hospital are not considered as being two separate services divided by an illusory Berlin Wall. I mean, we should be seen as one team. And Nitin is a urologist who should be on the same side as me as a GP. And we should be both looking after patients who've got urological problems, rather than what is currently a ridiculous situation where I have to refer patients who then are shunted back to me for a prescription. And then Nitin's asking me as a hospital doctor to do a test in 2 weeks. I mean, the whole thing is just toing and froing, and patients lose out. There are better ways to design the system that can actually release huge amounts of wasted money, make it much more streamlined, and be better for the patient. And this meeting today we don't have time to go into details, but there are plenty of service redesign opportunities here to achieve exactly what Nitin is describing.
Thank you. And MC, thank you very much for joining. If you want to put your point, please.
Thank you, Chair. Hi, Chand. Long time no see. Great to see you. Thank you for everything you've done for us over the years. I just wanted to make a few comments, if I may, Chair. One is on the workforce. We never seem to have accurate figures on workforce, ever. And one of the things that has always concerned me is if you count the number of partners, that can actually tell you how many people are actually working on a day-to-day basis in a practice. I know lots of partners in practices who do 2 sessions, 3 sessions, and that's it. So we need some really accurate figures for primary care, and I'm just relating that to Brent. On the question of the extra workload, I completely agree with you, Chand, that there's an awful lot of clerical stuff that we do, and our partner organizations really need to have a look at themselves as well. So I'm talking about the secondary care sector, particularly in terms of people on waiting lists, etc., and also follow up for appointments and all that. And I come back to to now the system that we're working towards now, which is the ICB, one system across, say, Northwest London. And if you just relate that to Brent, I can think of many, many instances where colleagues will have seen a patient of mine and they could have done the necessary. So it's, the make every contact count approach. Okay. And so, I would encourage our partner organizations really to have a look at themselves and see what they do. So for community services, there's absolutely no need. If a district nurse is going into a patient's home, they're equally able to take a blood pressure if they need to, or a weight, or a urine analysis, or whatever, or even bloods. We don't need to send lots more people in, or we don't need to call patients in to do that sort of thing. And I think that if we start looking at how we maximize the use of the current resources that we have, within our community, within our acute trust, within our primary care, then we can all do better. And we can cut down the number of interactions that patients actually need, because patients don't want, 10 different people saying to them. What they want is people to do the right thing when they need them. And the thing about medicine is that when you go and see a patient, it's not just one thing that they want. They probably want 2 or 3 things. And we need to be able to have people who are able to sort those things out quickly for them, because it's immensely frustrating for patients. And Orleen Hilton, I'll come back to your point about, you making the telephone call to the surgery and the reception staff saying, well, you've got to do it online. That I put the blame on the senior partners within the practice, because they're the people who give the instructions, right? It's not the receptionist making rules up. It's not necessarily the practice managers. That responsibility lies with the GP partners who make those everyday decisions within their practice. And it's not right. If you want to be able to speak to somebody on the phone or make an appointment by ringing your practice, you should be able to do so. You shouldn't have to be made to go online. I think that's an absolute necessary thing to achieve, especially for Brent. There's lots of people who cannot manage to go online, and we can talk about digital exclusion and what we're doing to reduce digital exclusion. Nevertheless, there'll always be a proportion of people for whom it's more convenient to pick the phone up. And then that comes to telephones. We've got PCNs now. There's absolutely no reasons why PCNs now can't get together and have back office functions doing all the stuff that GP practices have to do on their own. Thank you very much.
Thank you very much. Really good to see you. A quick and final point from Diana. Diana, please.
Thank you, Chair. Thank you very much, Dr. MC Patel, for what you've just said, because that is exactly what is needed. Senior management or senior partners within the GP practice has to put those parameters into place. And this is something that's been going on before COVID. It didn't just start, and this, it has nothing to do with inequality or anything like that, one person being treated better than the other. It's about how they address their system, how they set up their management procedures, etc. And that's what I want to hear this evening. Is there any form of solution that I work as a health educator, and I'm inundated. I have myself and my colleagues, we have so many issues, with people wanting to say we can't get in, we wait for an hour, etc.
Thank you. Let me just...
How do we go about that, please?
Diana, thank you very much. I don't know whether Jonathan wants to very quickly see if he is able to turn off. Can you turn off your mute and see if you can be heard? Otherwise, I know your colleague Varsha is online as well, and see if Varsha is able to perhaps come in here very, very quickly. No, we can't hear you. Varsha, I don't know if you're still with us. I can't see you on my screen, but there are lots of different pages. But if you are still there, I don't know if you can come in. No, okay. Perhaps we'll pick this up offline, Jonathan. Chand, any final word on what we just heard from MC and Diana?
Yeah, so I mean, I think MC has hit the nail on the head about the fact that so much in the NHS is fragmented and we do duplication. And that's because each bit of our providers work in silos. And in fact, the system does create those silos in the way where we have separate budgets. And that's one of the reasons why we have the issues around, for example, getting a GP to prescribe a drug rather than the hospital doctor to prescribe it, because it comes from a different budget and it's the wrong reasons. And similarly for the community nurse that MC mentioned, if they're visiting a patient to do a leg dressing, they won't give the flu jab because it's not, funded for, and all sorts of, we need to break down those barriers. We need to put the patient first, and we need to get to a system where all of us, those working in hospitals, those in community, those in general practice, actually work as a seamless, single profession, multi-professional unit. And we make, as MC said, every consultation count. And we also make sure that the right patient, the patient sees the right professional at the right time, and make sure that no one is barred from being able to access the care that they need given their particular circumstances. And that covers anything from those that do not want to use online, right through to those that may have certain
Thank you.
disabilities. So I think that's what we need to do.
And I think that is a wonderful note to finish on. And I think that could, in fact, be the final summary. Chand, you have given a fantastic summary of what we need to do going forward. With that, let me bring Judith back, please. Judith, if you could just have a moment for your final word and a word of thanks, please, before we conclude this session. I told you 1 hour was never going to be enough, and look, 1 hour has gone so quickly. But thank you very much. And as I've said, this is just the start of conversation, and no doubt we will want to come back and do further deep dive into 1 or 2 areas that we touched upon this evening in much more detail. Judith, over to you, please.
You're on mute.
Judith, are you?
Sorry, there had to be one, didn't there? I do apologise. So as we said earlier, we will send the recording round to everyone that's been here today, all the people that gave us apologies. We'll also send the slides. What an amazing discussion. So many great questions in the chat didn't get answered, but really, really great questions. But, you know, thank you, Dr. Nagpal, for a really insightful, honest, great presentation, wonderful way in which you answered the questions, and thanks to Councillor Sheth as well. I think we need to have another one of these sessions on access to GP services, and maybe we could begin the next one from kind of where we've got to at the end of this session and start looking forward to more co-produced solutions as we're starting to get to. But before I update on what the next 2 lectures are going to be, I'd really just like to ask everyone to join in saying thank you to Dr. Nagpal and to Ketan.